One more time, I'd just like to thank you for joining us this afternoon. We're very happy to have you. This will be a presentation on bioethics in the time of COVID-19, presented by bioethicist Dr. Gregory Pence. And I would like to kick off today's program with some introductory remarks by UAB Provost Dr. Pam Benoit.
Good afternoon. It's a pleasure to welcome the alumni of our Early Medical Student Acceptance Program, MSAP, UAB faculty and staff, and UAB medicine healthcare practitioners. Thank you all for your continued efforts in combating COVID-19, whether working on the front lines in patient care, teaching effectively in online and hybrid settings, or helping us to maintain a safe campus environment. And to our MSAP alumni, thank you for your continued support and involvement. Today's presentation addresses the very timely topic of ethical issues facing healthcare providers during the COVID-19 pandemic. We're pleased to have as our presenter a nationally renowned authority on bioethics, UAB's own Dr. Greg Pence, who continues providing outstanding leadership in this field during a time of great uncertainty. Dr. Pence helped to found the field of bioethics and has done pioneering research and scholarship for more than 4 decades, including his best-selling textbook, Medical Ethics, now in its 8th edition and 27th year, as well as some 70 essays in such publications as the New York Times, the Chronicle of Higher Education, and the Wall Street Journal. He joined UAB in 1976 and was course director of medical ethics in our School of Medicine from 1997 to 2011. He's currently professor in our philosophy department, where he served as chair from 2012 to 2018 and has been instrumental in developing our bioethics program. And of course, Dr. Pence is the director of MSAP, a highly acclaimed program that he's built and cultivated since 1995. He also coached both of our ethics bowl teams and our bioethics bowl team, which he led to victory in 3 bioethics bowl national championship. I think we have a number of people who are on those teams with us today. Recently, UAB was pleased to present Dr. Pence with the 2019 Ireland Prize for Scholarly Distinction, and we are delighted to have him as our speaker today. Thank you all again for being here and for your support, and I know that you're going to really enjoy this presentation.
And now we will hear from renowned bioethicist, author, longtime director of the Early Medical Student Acceptance Program, and longstanding UAB faculty member, Dr. Gregory Pence.
Hi, Nikki. So can we bring up the first slide?
Yes. Just one moment. That is loading up here.
And thank you, Dr. Benoit, for that very lovely introduction. So it's kind of weird talking to everybody. I wish it was a little bit more intimate in COVID world, but we have to do things virtually. And let me just say that talking about ethics during a pandemic that's affecting everybody on the globe is certainly a humbling experience. And it's even more humbling at a time when we've lacked national leadership. But one thing I knew back in January when China quarantined 8 million people was that this was going to be a huge issue in bioethics, maybe the biggest issue in my life. And I immediately started talking to, as students listening know, I started talking to people, writing about it and thinking about it. And so for those of you who know me, it's no surprise. Next slide, please, Nikki. That this spring, Broadview Press will bring out a book of mine called Pandemic Bioethics, where I try to go back in history, like this is this picture of the Spanish flu, and talk about some of the huge bioethical issues that pandemics create. And they change. What I'm talking about is true I think on November 18th, 2020, but who knows what they'll be a couple of months from now. Next slide, please. So it looks like we're going to have a successful vaccine, an RNA vaccine. And that's not the end of the ethical issues. It actually is just the beginning. The two vaccines we have are not perfect. They, in the trials, they were just testing whether people get sick, not whether they've actually had the virus and are asymptomatic. So we need to learn some more about them. But I'm going to focus on the ethical issues they create a little bit today. And the first one has to do with international issues, which you may not have thought about. Next slide, please. Oh, sorry, I got ahead of myself. We know that under the Trump administration, we had Operation Warp Speed, which is a little bit scary because although it's good to have a vaccine fast, we don't want to cut corners. And not everybody knows that when the first national mass vaccination program of polio, we did cut some corners. One of the batches made in California, it was supposed to have dead virus or weakened virus, but it had live virus. And 64,000 children got live virus. 160 ended up with varying degrees of paralysis, and 10 were dead. And this was the beginning of the modern anti-vaxxer movement. So we have to be very, very, very careful that our vaccines are safe. Next slide, please. So one of the things that's going on right now is that the Trump administration is practicing what I call vaccine tribalism or vaccine nationalism. It quickly paid $2 billion to Moderna and $2 billion to Pfizer and $2 billion here to a whole bunch of other companies to basically gobble up all the vaccines for Americans first. And although some people would probably applaud this, it's not the approach that a lot of other people would take. Vaccine globalism is favored by something called Gavi, the Global Alliance for Vaccines and Immunizations, which is an alliance with the Gates Foundation, the World Health Organization, the World Bank, and private donors. It's basically nonprofit and is trying to vaccinate the whole world. Next slide, please. And the hallmark in Gavi, the leading institute is the Jenner Institute at Oxford, which is doing the AstraZeneca vaccine. It's nonprofit. It's been developing vaccines for years. And it intends, when it gets a successful vaccine against COVID, to deliver it first to all the essential workers around the globe, not to any particular country. And I don't think vaccine tribalism is really going to work because we can't just stay in our country forever and not have anybody come here. We can't seal ourselves off from the world. So it's, in order to fight this world global pandemic, we're going to have to figure out a way to vaccinate almost everybody on the globe. Next slide, please. So another thing that's a successful vaccine raises is a national issue. And one of the things I think is really important is that the distribution of the vaccines should not become a political weapon. We don't want something we've already seen where the president has said to New York, "You're not getting the vaccine." This is really, really bad. So, but things could get even worse. The president is doing some crazy things right now. It's kind of scary. It could, the worst case scenario would be that only Republican states get the vaccine first, or even worse, only people that are approved get the vaccine. This would create no trust and just be the worst possible scenario. I hope to God it doesn't happen. Next slide, please. So one of the things that history teaches, which is interesting, is how we're making some of the mistakes that people made with the Spanish flu. And there's been a bunch of great books about the Spanish flu. It's not really studied because people were sick of all the deaths from World War I and from the flu. And as soon as when it was over, the Roaring 20s happened and people just forgot about it. But if you look back, the cities that didn't do well, they shut down late, they were inconsistent, they reopened too soon, and very important for our time, they had public officials who contradicted each other all the time. There are some countries in the world who are doing wonderful, and they tend to be led by women. New Zealand, Hawaii, Scotland, Iceland, South Korea, Vermont are all doing well. They're doing just the opposite. They're doing everything right. Next slide, please. There are some really bad things coming. We know that the numbers in Alabama, just for Alabama, are really bad. In 8 days, we've had over 17,000 cases. We see the numbers keep rising nationally, and we know the flu is coming. So, and the vaccine is probably not going to be here in 2021, and a lot of people aren't going to take it. We have to think about how to get through this winter. Next slide, please. So someone really needs to think about right now a coming flood of COVID patients. Here's a field hospital in the fairgrounds of Milwaukee, which just got built. The ER at Las Vegas and Utah is starting to be flooded. Things are really building up fast. The hospitalization rate in the state of Alabama has jumped from 600 to 1,300 in a couple of weeks, and it's probably going to explode when flu season hits. Next slide, please. Unfortunately, this flood is going to exacerbate all the problems of our existing medical system. We know that almost 30 million people lacked medical coverage in 2019. We know that a lot of people only get their coverage by working. We know that a lot of people are unemployed right now. Many have lost their medical coverage. And there's millions of undocumented workers who lack coverage. And yet they're most likely to work on the front lines, get infected, transmit the virus, and be reservoirs. So unfortunately, all the problems of our medical system are going to be intensified by COVID and flu. Next slide. So one thing we can do ethically, we don't need to block testing for COVID by ability to pay. There are stories around where somebody got a test for COVID and had to pay $1,800. That's not going to work. If you charge people for tests, you'll just keep the poor people away and they'll just stay away affected. In the same way, we shouldn't block people from getting treatment by ability to pay. If poor people stay away because they're sick and spread the virus in the community, that's bad. So in short, we can't stop a pandemic only by testing, treating, and vaccinating the rich Americans. Next slide, please. So we also know that some COVID patients now stay in the ICUs for months. We see people coming out on the news every night who've been in there for months, and it's a big success. But gosh, staying in the ICU for that long is going to fill them up really fast. I don't know if we can continue as we normally do. Much of our ethics in the ICU in the hospital is based on what I call, and bioethics is called, care ethics. And that is that when a patient enters your circle of concern, you do everything possible for them. And basically, we operate that way on a first come, first served basis. We don't have a triage officer. Next slide, please. And bioethicists have thought a lot about some of these issues about allocation. There's a famous article by Jim Childress called "Who Should Live When Not All Can?" When New York was flooded, there was a lot of talk about who should get a ventilator. We've kind of finessed that now by making more ventilators and suppressing the immune reaction with steroids, but there's other allocation issues. Next slide, please. So it's not just the ventilators that are scarce when you start thinking about caring for COVID patients. It's ICU beds. It's a very admission to the hospital. It's access to respiratory therapists who are scarce. It's access to ICU nurses and even access to the ER. All of these are allocation issues, and they're all going to start flooding the hospital. Next slide, please. And we know that flu is coming, and flu kills a lot of people every year, and especially old, fragile people. So we're going to have like a double tsunami hitting very, very soon. Next slide, please. So there has been a bunch of conversations about how to allocate, and some of you know that Alabama and Washington State had existing protocols that were about 10 years old that were very controversial because they suggested that anyone with beginning dementia or Down syndrome or autism should be triaged and not get treatment. That went up against the Americans with Disability Act, and some disability advocates, and those two protocols quickly got chucked. But there are people who are saying the same thing. Zeke Emanuel, who you've probably seen on TV a lot. His brother was Rahm Emanuel, the mayor of Chicago and Obama's chief of staff for a while. He's been advocating a kind of utilitarian stance that we do all these allocation decisions based on maximizing life years. And that's pretty controversial because it basically says you admit the 26-year-old to the ICU, but not the 80-year-old. John Rawls, the famous author of A Theory of Justice, thinks we should protect the most vulnerable first. And then there's also a very smart physician named Doug White, who argues that we shouldn't do either of these. We shouldn't triage people with disabilities, but we also shouldn't waste resources on futile patients. And he has a matrix of 8 different factors we should use to allocate. But that's going to be really complicated. I'm not sure that's practical in the emergencies, in the ICU room and in the ER. Next slide. There's also a problem, I think, that Zeke has raised. And Zeke has claimed that there's going to be situations where we need to discharge an 80-year-old from the ICU and allow a 26-year-old to come in. He says there's no problem here. I think there is a problem. Next slide. My mentor, James Rachels, was famous for attacking the acting-omitting distinction. He argued that if the motive is the same in both cases of accepting death and in both cases death results, that there's no morally relevant difference between not admitting a potential patient to an ICU and discharging a patient from the ICU. That ethically they're the same, and you shouldn't focus on whether it's an action or omission. But I'm afraid I have to disagree. Next slide, please. As I said, I think when patients are admitted, they come into a unit, they come into your circle of concern, we want people at the bedside to be patient advocates, to go out to be intensely bonded to patients. And for them, discharging a known patient under your care in favor of a stranger is morally traumatic, and it feels like patient abandonment. I just don't see how we can let those people be forced to make those decisions. Next slide, please. So do we need somebody else? Some people have advocated having a triage officer who will take those decisions away from people at the bedside. This is a chart of triage. But I want to say, before we get into this, which is most bioethicists have spent a lot of time talking about, we may need to take a step back. Next slide, please. Do we want to get to the situation where we need a triage officer in the ER or in the ICU? I don't think so. We don't want to get to the situation where we have to kick old people out in favor of younger ones. No hospital wants to do this. Ask the hospitals in Northern Italy who had to deal with this. They were horrified having to do this. So we need to ask, how can we avoid getting there? Next slide, please. One answer, I think, is to have a national system of allocation of hospital beds and resources. It doesn't make any sense to me for a hospital in Charleston, South Carolina, to be denying admission to COVID patients when hospitals down the road in Savannah have available beds. We really need to avoid what I call regional tribalism. And this is already occurring with UNOS and how it distributes organs. We don't need one region refusing to take patients from another, especially when it's got available resources. I think we're all in this together, at least we should be. Next slide, please. Here's another thing we should plan for. Let's assume the worst, which may actually happen. Let's have a plan to turn gymnasiums and convention centers and National Guard armories into field hospitals. Let's have a plan to allow medical and nursing students who are in training, not just don't yet have a license to assist in care. If that happens, we're going to have to give them legal immunity. That already happened in New York, where some medical schools graduated students early. We may need to go a step further and let students way in the pipeline help. We need also to make sure that connected people and rich people and privileged groups don't access emergency care and treatment not available to everyone. This will create mistrust and civil unrest. We need national leaders that convey the idea that we're all in this together, and we should be. Next slide, please. I think it's time for a national mental reset. Probably the biggest thing we need to do in terms of avoiding triage situations is to somehow get everybody on the same page. We can't have a 3-month lockdown and then celebrate for a month. Europe did this, Spain did this, it didn't work. Some southern states did this. It's not working. Too many Americans want a quick fix, provided to us by techno jocks, so we'll quickly get immunized against the virus. In the meantime, they don't want to change their behavior. Next slide, please. There are some countries that are just doing amazingly well. New Zealand went 100 days without having a new case. Germany has an amazing support system for everyone not working. Iceland used decode genetics to track every case. People are and they're democracies. You don't have to do the high-handed techniques that are going on in China and Argentina. Democracies are doing really well. We're not. We are, if you look at the Hopkins site, India and Brazil are right behind us, but we are outpacing both of them every day. Cases are just exploding in our country. Next slide, please. So in terms of the pandemic and a mental reset, let me just give you a real simple example that happened in my own life. Well, I recently voted a couple of weeks ago at a little church in Mountain Brook, where we always vote. And some of my neighbors work there as poll workers. So the day before I went by and I asked them what plans they had for physical or social distancing. And they really had no plan. And so I asked them if I could go to Publix and get some blue tape and come back and mark off 6-foot distances, which I did. I put 100 of them outside, and the next day it worked perfectly. People were very orderly, and even we had 200 or 300 people in line, but they got the idea. On the other hand, across the city, in a church in Vestavia, it was pandemonium. People were bunched together. 5 poll workers got COVID. They want to test now everybody in line. And basically, because no one had accepted the idea that they're in a pandemic and they really need to think through everything about daily life. Next slide, please. I think we're out of sync in some ways with the natural world, and we need to think about how to get back in sync, and if not, how to prepare for a lot more viruses. Next slide, please. We know from virology that viruses are constantly mutating and trying to survive. We know we're surrounded by viruses. We know that in southern China with bat caves, there's huge amount of interaction between bats and humans. We know there are wet markets, international just-in-time supply chains. There's international travel that previously HIV and Ebola were isolated in Africa. Then we get an international airport and tourism, and they burst out. This is going to continue to happen. And I don't think we're going to go back in time and not have international travel, but if we need to accept that we're going to constantly have viruses trying to cross over, and we need to be on guard. Next slide, please. So at the most minimum, what we need now is a basic minimum medical care for everyone in America, including undocumented workers. We need a robust system of public health. We need to depoliticize CDC and make it the leader of the world again. And we need to cooperate with everybody in the world. We can't be an island in a pandemic. That's not going to work. We have to help everybody fight this. Next slide, please. There's a lot of other ethical issues that I didn't have time to talk about. Everybody's betting on immunity passports. They might create a new caste system. sometimes you hear about that people die because they have comorbidities, which implies, they're not healthy, but I am. This is a form of blaming the victim. We need to figure out how to help the most vulnerable. And we need to figure out why, especially Black and brown men over 50 are dying at such a high rate. Next slide, please. And that's it. Like I said, talking about a pandemic is humbling, and I have some opinions. I hope I give you something to think about. I'd be glad to take your questions now.
Thank you, Dr. Pence, for sharing your expertise with us today. I'm sure all of our guests found that very helpful. Again, I want to thank you, Dr. Pence, for sharing your expertise with us today. We'll now move into the Q&A session. We invite all of our guests today to please submit your questions in the chat. Again, if we're not able to get to all of your questions today, we will be sending out a message in the coming days with answers to these questions and a link to the recording of this program. So now we will start with our first question. It comes from Trevor Holden. He asks, during the lecture, you claimed the ability to pay ought not to inhibit access to the vaccine. Can this be applied to allocating medical resources in general? Does COVID-19 demonstrate how our healthcare should be universalized?
Well, obviously, I think, Trevor, that you're right, that every other developed country in the world has managed to have a single payer system that provides basic minimum care to all its citizens. And the United States still lags behind doing that. I see no reason why we shouldn't be able to do that eventually, maybe by expanding the Medicare for all idea. But yes, I think, and several people in the New England Journal of Medicine have written about how COVID may be the event that tips us over and brings us to a national system, which would be good. Okay.
All right. Thank you, Dr. Pence. We have another question here from Natasha Mira. How should we allocate vaccines here in the US?
Hi, Natasha. Thanks for the question. And I know you're interested in this question. Well, I think, and I think MSAP alumni are going to like this answer, that people on the front lines who are exposing themselves to the virus ought to get the vaccine first. We owe it to them. And I think maybe their families ought to also, because they're being exposed. And we also need to think about other people in the hospital, like the housekeepers, the cafeteria workers, all these people we depend on, and the people out there doing rescues, driving the ambulances, CPR, emergency medical technicians, even the people who deliver packages for Amazon and UPS. Those are all essential workers, the policemen. We need them. And there's another epidemic going on also, the opioid epidemic. They're also involved with this and being at risk. So all the essential workers need to get the vaccine first.
Thank you, Dr. Pence. And it looks like our next question is, earlier in the presentation, you spoke about changing the national mindset of American citizens. What is an effective starting point for changing these patterns and behaviors in the status quo? How long will it take to truly reset the national mindset?
It would be nice to have a leader like New Zealand has who tried to create, and also even Trudeau in Canada, creating a sense that we're all in this together and we need to help each other. Hopefully, President-elect Biden can do that, and he's going to have a huge hole to dig out of. It may take another event. With HIV, you may recall that for a while, everybody thought it was disease of other people with a capital O. And it wasn't until people got infected from blood transfusions, from Rock Hudson got infected, that everybody started to take it seriously. So we may need a sentinel event like that to get people's attention. Also, in the Spanish flu, if you read 100 years ago, people didn't, the whole nation didn't take it seriously until they knew someone who had died. And I hope we don't have to get that far to that point, but it may take that.
Thank you, Dr. Penance. And our next question comes from Dr. David Chan. Triage assumes finite and exclusive options. The problem of choosing between an 80-year-old and a 26-year-old seems to assume only two options. I know an ICU bed or ventilator is not a divisible resource, but I wonder if there is a way to provide a lower level of care to some so that more can have care.
Absolutely. And I think that's a great question and a great idea. Although people have split ventilators in extreme situations. But yeah, all kinds of ways to avoid the ultimate bad place where you have to make a decision about kicking someone out. In ethics, tragedy is defined, like in Sophie's Choice, as where you only have two terrible choices. We don't want to get to that point. And I think that, especially by looking at what China has done and what other countries have done, we may be able to have a stacked system, a tiered system, at different levels of care. And, you know, ultimately there may be some small triage in there, or people are, you know, 90 years old and have 7 different problems. We know that just going to the hospital is really at risk for them of dying. So, but yes, we need to think about a whole different ways of having levels of care.
Thank you, sir. Our next question. Can you provide your thoughts on COVID testing and parental custody issues? We have encountered situations where one parent is trying to limit access to children by using COVID. Are there any judges that are requiring testing prior to parental visitation and custody?
Wow, that's an interesting question, especially if the parents don't agree about risk protection, you know, mask wearing and physical distancing. So I would think that any good judge would take that into consideration. And, but of course, just in the same way that COVID blows up the inadequacies in our medical system, if a couple is fighting over child custody, unfortunately, everything about COVID may just make it worse, especially if they're on opposite sides of the political fence. That's a great question. And I'm glad I'm not a custody judge.
Absolutely. Our next question comes from Stephen Yoder. Should vaccines be mandatory, i.e. no vaccine, no school?
It's interesting that Stephen Yoder is asking this question from UAB. And I actually discussed this with my students. And, you know, I think in class the answer was, well, it depends. If it depends on what stage the vaccine is in. There was a big feeling that if it was mandatory because Trump says it's safe, that they aren't going to take it. But if Anthony Fauci and Francis Collins all take the vaccine, then I think a lot of students would like to take it. And even to say it's mandatory, I think all that means is you can't be on campus unless you're vaccinated. It's like we're now doing with testing. And of course, people could not be vaccinated and still attend remotely. So I think if it's a good, safe vaccine and we trust the people who are telling us it's safe, it's a reasonable requirement for a safe campus to have everybody vaccinated.
Thank you, sir. Our next question comes from Trip Ference. He says, thank you, Dr. Pence. I agree with most everything you said, with one exception. In terms of protecting the vulnerable, should medical trainees be considered in this group? Trainees may be easily coerced by supervisors, may lack proper PPE training, and lack true informed consent.
Oh, yeah, I think the trainees are incredibly vulnerable. You're right. Um, and I think this, for a while, was an issue in dentistry where dentists have done really well with COVID for the most part because they were really good about infection control beforehand and they just ramped it up. But getting enough PPE for all the dental students and the hygienists in training was a really big issue. And for a while, everybody had to sort of stay out of the clinics. But yes, they're very vulnerable, especially because everybody to get there is fairly ambitious and you've learned to go along, even if you're putting yourself at risk. So yes, you are vulnerable and yes, you should get vaccinated along with everybody else right away, in my opinion.
Thank you. Our next question comes from Malik Hossein. I agree that better planning and a national mindset can help ensure we have a better allocation of resources for individuals. However, the ethical issues bite when resources are scarce. How should we design a triage system? Fairness is important, but the economic argument is that allocating by willingness to pay provides an incentive to manufacture more resources in the long run.
Well, hi, Malik, coming to us from the University of Pennsylvania and former member of our Ethics Bowl National Championship team. That is a tough question, but I don't think a pandemic is the time to start a kind of libertarian marketplace approach to medical care, which is in some ways more efficient if you're selling Botox. But our basic problem is if rich people buy access to testing or vaccination or treatment, that's okay for them, but it's not okay for solving the pandemic because the virus will still go everywhere. And my own view in terms of the economy is our economy is not going to reset and get back to normal until we get a handle on this virus. We can't just talk our way out of it. And so the market is going to be kind of on hold until we can figure out a way to stop the pandemic. And we can't stop the pandemic individually. We have to have a group approach. So that was a tough question, Malik, but thank you.
Our next question comes from Christian Heersink. What are your suggestions for how we can move forward in terms of international travel? For instance, the Netherlands has exceptions to their closed borders for people entering to further green energy initiatives or who have a relationship with a Dutch person.
Yeah, hi, Christian. And I know what you would like to travel back to Holland. That's a little bit tricky because even some of the tests at the airport and before you leave, some of them are not really testing for the virus, and they're not really guarding against asymptomatic people. So I do think there'll be levels of screening that will enable international travel for some people, and some people are willing to take more risks than others. I think the cruise industry is in big trouble because mostly elderly people take cruises and they're at the most risk and they're so confined for such a long time. But certainly airplanes have the capacity to spread people out more, to filter the air. I think it'll probably be tested at both ends, and it'll be something like an immunity passport. And that's probably where we're gonna be the end of next summer. We may have may have more than one vaccination, and still, even if you're vaccinated, you still may need an immunity passport to show that you haven't got the virus as a reinfection or some other way. So I think I think there will be some international travel, but I think it's going to be like flying the the, the Boeing plane that just got approved to fly again today. I mean, that's gonna be for some people willing to take risks.
Thank you, Dr. Pence. Our next question comes from MSAP alumna, Dr. Jennifer Gandhi. You spoke of the politicization of allocation of vaccines to states. How can we combat the politicization of simple, effective measures such as mask wearing?
Hi, Jennifer from California, or I think she's a psychiatry resident. I really hope that we don't get to blue states versus red states getting vaccines or getting ventilators. This has been horrible, the fighting between states and stealing from each other. And I am so much hoping for, like I said, a national reset where we're not so divided about the simplest facts. It did happen with the Spanish flu where some people resisted wearing a mask, but even back then in 1918, they knew that wearing a mask and not being at large gatherings reduced the spread of the flu. We've had the most politicized pandemic maybe in the history of humanity. And we're exceptional, America, in this way. Other countries have some pushback, but it is just incredible in America. And unfortunately, it's the hospital workers, the medical students who are ultimately bearing the brunt of our political divisiveness. You're on the front lines and you're the ones that are going to be overwhelmed. You're vulnerable. And I wish we could help you more by doing our part outside the hospital.
Our next question comes from Ashka Patel. Thus far, it seems many of the mechanisms in which we have tried to stop the spread of COVID have primarily been guidelines, but not very enforceable. Do you see this changing in the near future?
Yes, I do. And I think it would be a good thing. I don't think people have a right to go into a store and not wear a mask or expose other people to risk. It's a pretty old principle of ethics and Mills harm principle that, you know, if you want to harm yourself in your house by smoking or drinking too much, that's okay, but you shouldn't get in a car and put other people at risk. So insofar as not social distancing, not wearing a mask potentially harms other people, I think it's certainly enforceable and finable. But of course the fines need to be substantial enough to change behavior, not just tokens. And you know, we see the rules that when I went to UAB Kirkland Clinic in the hospital, everybody's required to wear a mask, and some woman tried to barrel past the guards and say, "Oh, I can't breathe with a mask," and I got her quickly and escorted her out. So we can enforce this, and you know, in the Asian countries, they've had some more experience with SARS before and epidemics, and everybody wears a mask all the time. It's not a big deal. It's even a mark of being a celebrity. We just need to get with it a little bit.
Our next question comes from Greg Pavella. Did you learn anything about pandemic ethics while teaching public policy of pandemics during a pandemic?
Yes, I've learned that people are very interested in the topic. And a lot of people are going into, Greg is a professor of public health, and people are streaming into public health because they're interested in the field, and it looks like there's going to be a lot of jobs in it, and there's a lot of public policy and ethical issues, and I think they're just going to keep growing and growing. We're all going to have to be experts on vaccines and their risk. Suddenly, the hottest majors now the university are immunology, public health, virology. Everybody wants to be part of the solution and thinks that a lot of research and publication is going to occur, and a lot of money is going to go into these fields. So, and I also learned what um, I was teaching in a global health program of graduate students, and how um, it was really great because there were people in like Nigeria and Washington, D.C. running hospitals, and they brought a lot to the course, their own personal experience uh, with infection control and public health. So uh, I like that program.
Our next question comes from Joyce and Leah. Federal restrictions on social media to limit disinformation. Your thoughts?
It's really interesting that the Moderna vaccine is about ready to be rolled out in England, and they're very concerned in England that there's a huge amount of anti-vaxxer stuff being put on the internet and social media, and even by groups that may be associated with Russia or competing countries with vaccines, and they're actually going to shut that down. There's a bill in Parliament to shut down all anti-vaxxer posts on social media. I think that's too much, because there are some legitimate issues that have occurred in the history of vaccines. Some people are allergic to chickens where some vaccines are made. We had a problem with the swine flu vaccine previously, and Guillain-Barré syndrome. Vaccines don't cause autism, as one of the biggest lies in the history of vaccines. But I wouldn't want to limit rational discussion of the pros and cons. I do think malicious false information should be regulated.
Thank you, Dr. Pence. Our next question comes from Grace Brown. If we are to have a more well-rounded and universal approach to healthcare access and affordability solely in regards to COVID, do you think when the country begins to get a better handle on the pandemic, this would lead to universal access to healthcare as a whole?
Yes and no. So if we could come to the point that New Zealand came to, and Iceland, and a little bit Hawaii, where the idea that we're all in this together, and of course, islands can handle pandemics a lot better than our country. We have huge porous open borders, but the islands basically thought, hey, nobody's coming to help us. And we may even be cut off. So we have to handle this problem. And they did. And the same thing happened in England, an island, during World War II, when they almost lost. I mean, they didn't know they were going to win. And they all hung in there together. And after the war is when they started the National Health Service. And partially the idea of that was in gratitude to the nation for getting through that war, that we all hung in there together, and now we need to heal our wounds. And we don't want to deny anybody care by ability to pay. So I think that if we could get to that point where the Spanish flu lasted 2 years. Hopefully this one won't last this long, but it could last even longer. But at some point, we need to all be together fighting it. And if that happened, I think it would be a very natural segue into creating not a national medical system for everything, but a national minimum for care.
Thank you, Dr. Pence. It's approaching 4 o'clock, so the next question will be the last question we're able to take. In the coming days, though, we will be sure to share answers to questions not covered today and a link to the recording of this program. If you haven't done so already, please remember to share your name and email address in the chat feature to receive a follow-up message with both of these items. Our last question comes from Trevor Holden. Is overcoming COVID-19 in the US, if overcoming COVID-19 in the US is about resetting the national mindset, how do we tackle those who outright deny the pandemic's existence?
Well, one thing, we should sell little buttons that say, I don't want a vaccination because the pandemic doesn't exist. Or another button that says, I don't think the pandemic exists, so if I get sick, don't take me to the hospital. We hope all the anti-vaxxers line up and volunteer not to get sick and not take the vaccine. At least they put their money where their mouth is. There's, you know, there are a lot of crazy people on the internet. And one of the things that, if you look back, we thought that things like Facebook and the internet were going to be benevolent things, so everybody kindly shares information. We didn't really anticipate the dark side of social media and how this would exacerbate tribalism and how people could peel off and only talk to each other and fuel each other's craziness. We've never, in terms of the ethics of technology, we are way behind dealing with the pernicious effects of social media and the internet. And we need to figure out a way to do something about it. People are making a lot of money off of us, especially in a pandemic. And we need to figure out a way to rein some people in who are using it in bad ways. And also, the biggest question is that there is no name for Baby Yoda over there. I simply call it the child.
Thank you for that, Dr. Pence. I would like to ask, do you have any closing remarks you would like to share before we go to Carrie Chestnut for final closing remarks?
Yes, thank you all for coming today. And like I said, this is the first one we've ever done like this, and I think maybe we can do another one where we can all see each other and interact more like a intimate Zoom meeting. We'll try to figure that out. And if you would like that, please give us some feedback, and maybe we'll figure out another way to do it. Thanks for coming today.
Thank you very much, sir. We appreciate your expertise. And now we will go to Carrie Chestnut, who will provide final closing remarks for this event. Carrie, take it away.
Thank you so much, Nikki, and thank you to Dr. Pence for that wonderful presentation. And thank you to all of our attendees today. My name is Carrie Chestnut, and I'm the Director of Development here at UAB. As many of you on the call are MSAP alumni, you have likely experienced the tremendous impact of Dr. Pence's mentorship. And on behalf of Dr. Benoit, I'm excited to announce that UAB is actively working to establish the Dr. Gregory Pence MSAP Endowed Support Fund to ensure that Dr. Pence's legacy lives on in the MSAP program and here at UAB. Thanks to the generous support of many MSAP alum and others, we look forward to establishing Dr. Pence's legacy for generations of MSAP students to come. We have been so encouraged by the positive response and excitement that it has generated thus far. Thank you to those of you on the call who have already given, and it would be our honor to add your name to a list of colleagues and alumni who have generously supported this effort. The link for making a gift is now available in the chat feature, and please be on the lookout for an email tomorrow that will provide information on how you can make a donation. I look forward to getting in touch with you all to hear more about how Dr. Pence's work has influenced you in your career. We thank you so much for joining us today, and we hope you have a wonderful afternoon.